Welcome to the other side of Letby. In episode 39 and 40, we're going to finish off what I think about baby F and baby L. And to do that, we really have to go back and recap baby F first. We know that baby F was a twin. Baby F was born premature. At the time of the so-called incident, baby F weighed 10% less than its birth and had a diagnosis of sepsis, respiratory distress syndrome and dehydration. The defence of Lucy Letby in this case was appalling, just simply appalling. I have no idea how these charges made their way onto an indictment, because there's no evidence that you can actually call evidence in any of these cases. If we go back to the start, BBF had hyperglycemia right from transition from womb to extrauterine life, and it had to be treated with insulin. So we have a baby with a profound inability to maintain blood glucose right from day one. Then we have a gap in the evidence. That gap is from the 31st of July to the 4th of August. So we have a gap, 5 days, during which time we don't know what the baby's blood glucose was. We don't know what the baby's feeding regime was, and we don't know what the baby's TPN was. We don't have any of that information. We're just going to jump straight into the 4th to the 5th, because that's when Letby was there. And remember, in this unit or this ward, you can only have an unexpected and unexplained event when Letby's present. I like to call it Evans syndrome. Evans syndrome is basically whatever you want it to be. You can take any collection of symptoms and bundle them together. But the only constant finding in Evans syndrome is the presence of Lucy. Once you put Lucy Letby there, then you can make up anything else you like, and there you have another example of Evans syndrome. So all the babies died of Evans syndrome. So we have this gap anyway, and we don't know what the feeds were, we don't know what the TPM was, we don't know what the basal metabolic rate is. That's how much glucose did the baby need to maintain a normal blood sugar while carrying out all of its other physiological functions. We don't know any of that. But what we do know is that on the night of the incident, which was the 4th into the 5th of August, the baby is now on day 5 to 6 into life. That's when they alleged that Letby poisoned this baby, even though they have absolutely zero evidence for that. None whatsoever. No forensic evidence in the insulin bags and the immunoassay test. We'll talk about that in a minute. But just get an idea of what's going on here. They start off at 11:30 p.m. a blood glucose level of 5.5, and that's on August the 4th. Letby's been in her shift from 8 o'clock. A TPM bag has obviously been running in the baby, but we don't know what it is, because it says at 12:25 a.m. a 48-hour bag prescription of nutrition is signed solely by Lucy Letby, recording it ending. So they've taken down the old bag, and now they're going to have to administer some new TPM, and we have 2 records are shown for the next administration. The first one being crossed out. So that tells us they didn't even really know what to give the baby. They wrote down one, somebody that crossed it out, and they wrote down another one. The second nutrition bag was a higher level of baby vin. Now you can't have a higher level of baby vin because baby vin is a registered formula. It's 10% dextrose with some amino acids and electrolytes and trace elements in it. That's what it is. And then alongside quantities of lipid. So they're going to give lipid with that. But then weirdly, they say, and 10% dextrose that weren't on the first. So with the baby then, they're giving 10% dextrose. Now they're going to give more 10% dextrose and quantities of lipid. But in any event, they don't seem to know. They really want to give here. But anyway, the baby then is started at 12.25. The bag is discarded and they're now starting baby vin. Baby vin is a standard form and the lipid administration is to start at 3 a.m. And it says that Letby is co-signer for both baby vin prescriptions. That really makes no sense at all either, because you're using a 48-hour bag. What's the point in signing two 48-hour bags? Because if one of them lasts for 48 hours, you're going to have to chuck away the other one because it will be outside of the 48-hour lifespan of the bag. So this is just completely confusing. And then it says that at 12.25, the TPN starts. So is that one bag or two bags or what is it? Don't know. And then BBF suffered a deterioration, the court hears. A fluid chart shows BBF at 1 a.m. NGT, nasogastric tube aspirate, vomit, column 4+ signs. The nurse's note written retrospectively in time for 1 a.m. records large milky vomit. Large milky vomit. So that's the first thing that happens. And that is followed by an increase in heart rate up to 200 to 210. And the respiratory rate increases to 65 to 80. Well, of course, the respiratory rate is going to increase because it now has to give more oxygen to the baby to keep up with the increased heart rate. And the heart rate is not particularly high, but it's high. So the baby's going to be burning a lot more glucose now with this increased heart rate. But they have somehow managed to tie the two of these events together when they have absolutely no evidence that the two events have anything to do with each other. They say that they're going to ask Dr. Harkness to review the baby. They're not overly concerned. And then they carry on at 1:15 a.m. The heart rate is shown having increased along with the respiratory rate into the yellow area. Right? We're not in the danger zone yet, which the court has heard previously is something medical staff would note and raise concerns if necessary. It's yellow, green, yellow, red. No need to dramatise it. Prosecutor Nicholas Johnson says the relevant nurse will be asked to give further details on this in due course. And at 1:54 a.m., that is about an hour and a half after they've changed the TPN bag, they do a blood gas reading where they measure the glucose, and it's 0.8. Now, the first thing that has to be said is that is worthless. So as a consequence of that, they give dextrose, strangely enough, at 2:05. It says medication of 10% dextrose is administered intravenously at 2:05, along with various other medications. Now, I don't know what the other medications would be. And at 2:15 a.m., blood tests are ordered for baby F by doctors at 2:15 and at 2:17. So why would you do two blood tests separately and not from a single draw? And they're collected sometime between 2:30 a.m. and 2:45 a.m. But at 2:55 a.m., say 30 minutes after they give what appears to be a bolus, that's a jolt, single quantity of dextrose, and we don't know whether it's given mechanically by hand. We don't know whether it's given by this timed pump. But 30 minutes later, they check the glucose, and it's gone up to 2.3. So the baby is responding appropriately to a bolus of insulin. But these people want us to believe that Letby has spiked this TPN bag with enough insulin to kill a horse. At 3:10 a.m., there's no further change. They've just accepted the 2.3 reading. There's no further change in the dextrose or the glucose infusion rate. They haven't altered that. 3:10, they start giving lipids. And then at 3:50 a.m., a 10% dextrose infusion is recorded. So you can see why this is so weird. It seems as if there's three elements to this TPN. There's BabyVin. So maybe it's BabyVin, which doesn't contain dextrose. It just contains the electrolytes and the amino acids. Then they're giving the dextrose separately, but it appears that they've only started it at 3:50 a.m. And then the lipids would be the third arm of this three-element TPN. That is the only way I can make sense of this. I can't see why you would want to give 10% dextrose running on two different lines, because it's much more difficult to calculate the glucose infusion rate. But if that's the case, then they're alleging that Letby introduced ActRapid into the non-dextrose bag. Well, they don't make that clear, but the dextrose bag doesn't start until 3:50. Letby was the one that put up, or allegedly put up, the initial one that started at 12:25, and that doesn't appear to have had glucose in it. But there's a huge problem with that. If that is the case, you'd need to read this chart, but if that is the case, you're putting ActRapid into a solution that doesn't have dextrose in it. That's not going to go into solution very well. It's going to be unevenly spread throughout that 500 ml bag. So you're not going to be able to predict what a dose of ActRapid added to the bag would deliver at the other end of it, even taking into account the fact that 50% or more of the insulin would be absorbed by the bag and the giving set. It could be even way more than that. Even if you could calculate that, if there was no dextrose in the spiked TPN bag, then it didn't go into solution evenly. It's just how it works. ActRapid won't form a salt, like putting salt into solution. It binds with the dextrose in a different way to go into solution. You need it to have dextrose. And then at 4:25, further saline and 10% dextrose are administered. And at 5 a.m., the blood glucose level is 2.9. So, like, they're low, but not in the floor. And then we reach 7:30 a.m., the handover, and the blood sugar drops to 1.7. But again, we cannot go by these point-of-care readings. This one was done by Shelley Tomlin, so it's a point-of-care reading. It's not accurate, and it's certainly not accurate for forensic work. It's not accurate to be presented in the trial. So the defence should have picked up on all of this and said these readings shouldn't be allowed in a court of law because they're not accurate. And then at 10 a.m., so this is two hours later, after having recorded a blood sugar level of 1.7, Dr. Ogden checks it again, and it's 1.3. So they wait 2 hours from 1.7 reading, don't appear to do anything, and they record it as 1.3. And then they wait another 2 hours till 11:46 a.m. to measure it again and get it at 1.4. But they still haven't done anything to raise it up. So it seems clear that they can't manage the blood glucose levels. Either they don't know that these are too low, or they don't believe them because the baby's appearing very well. So then at 7 p.m., they finally decide to take action on this low blood sugar, and they scrap the TPN lipid and 10% dextrose administration. They scrap all that and they say, we'll just give 15% dextrose with sodium chloride. And these fluids are started at 7 p.m. Then we move into high force gear because we are moving into the second night. This would be the night of the 5th into the 6th. And the designated nurse from the previous night messages Letby to say that he's a bit more stable, his heart rate's coming down, but that the long line had tissued and child F's thigh was swollen. We don't know when that line tissued. It could have been tissued all of the previous day when these blood sugars were down, because it's going to take quite a while for the leg to become swollen, but it's now swollen and they're now noticing that the long line is, as they say, tissued, extravasated is the right word, but anyway. And they think that it might be the long line that is the cause of the hypoglycemia. Well, it's certainly not helping the situation. The colleague adds, changed long line, but sugar's still 1.9 all afternoon. So they must have discovered the long line tissued sometime in the morning after Letby left. But we can see that Letby's dead hand in the care of this child is long gone. We've that much swapping about of TPN bags and dextrose bags and this, that and the other thing. It would be impossible for anyone to know what the glucose infusion rate for this baby was and had they compensated for the tachycardia in the baby, which we'll talk about in a minute. So I'm presuming then that the 15% dextrose that they started at 7 p.m. is now going into the long line properly. And of course, it's going to take a bit of time when you start that dextrose. That's going to have to build up in the blood, in the tissues, because it's being used up as it's going in. But some of it will be going into stores that can maintain the rapid changes in the glucose demand that happens in the daily events of life. The glucose level in the blood, it moves up and down all the time, and you're going to need surges of it, and you're going to take them from the stores because the infusion rate isn't matching what you need. So that's going to take time. So that's going to take time to all level out, and it does level out because at 9:17 p.m., which is 2 hours after the start, the new line, the blood sugar goes up to 4.1, and you can take that to mean that it's probably okay now, because 4.1 is in the normal range. Then 6th of August at 1:30 a.m., they've got a 4.1 reading at 20 past 9. So they wait 4 hours to check it again, and they find that it's now 9.9. But they don't do anything. They wait 30 minutes to repeat it at 2 a.m. and find that it's still 9.9. Why wouldn't it be 9.9 still? Because they haven't turned the dextrose infusion down. And that, believe it or not, is the last we hear of baby F's journey through hyperglycemia, hypoglycemia, back into hyperglycemia again. We don't hear anything more about that now. We look at Dr. Gail Beach's confusing evidence as well, because again, they're mixing the 4th of August and the 5th of August together. And it says her first involvement was on the 4th of August, and the baby was on Optiflow. So the baby's on high frequency nasal warmed air. It has suspected sepsis, and that's noted. But it also has a raised urea and creatinine. Now, the creatinine is just, they're byproducts of protein metabolism breakdown products. And urea is the same, but they both are made different ways. You would be concerned about a raised urea, because the raised urea will indicate that there could be kidney damage or kidney problems with the baby. The creatinine wouldn't necessarily tell you that in a preterm baby, but the urea would be more of a concern. The baby also has jaundice as well. And she says that baby F was also establishing feeds. So they're feeding this baby, okay? But it doesn't mention that in the feeding chart of the night before. And then she tells us that baby F weighs 1.296 kilograms. But weight loss usually stops around about 3 to 4 days after the baby is born. And in general, and again, we can only refer to general, the maximum median weight loss is 5, something like that. And the 95th centile, so only 5% of babies lose more than 8.8% of weight. So with the dehydration and a 10% weight loss, this should be concerning, but obviously isn't to these people. They just mention it in passing. And then she confirms that baby F was receiving nutrition via A1 single TPM bag, and the baby F was active, moving all his limbs, the usual stuff, but it was still on antibiotics for sepsis. And they were going to continue increasing feeds as tolerated. Now we have to remember that baby F was on a ventilator, and so it's lost the opportunity to start its enteral feeds. It might have had trophic feeds. So these feeds that the baby is now taking are likely going to go through a nasogastric tube, and they have to be pretty small. They can't build them up too quickly. It can take 2 or 3 weeks to build up a healthy baby, preterm baby, to full enteral feedings, or even longer than that. But these guys are going to go gung-ho, and they're going to start building it up. And we know that because if Dr. Beach is talking about the 4th of August, the night of the 4th to the 5th, the baby has a large milky vomit. But the baby shouldn't be having a large milky vomit because it shouldn't be getting large volumes of milk. So again, we have feeding intolerance with this baby, or we have one of the house specialties of this unit, overfeeding and going too fast. And she goes on to say that baby Vin is a standard bag, and it would be given at a bespoke rate for baby F. So baby F is on, on the 4th of August, baby F is on baby Vin, 10% dextrose at a chosen rate for the baby. And that seems to be working. But then we're going to get into the 5th, we're going to start messing about with all that. So Dr. Beach says the second prescription with different baby Vin levels. So that has to mean a different rate. And new lipid levels were made for baby F. And baby F was nil by mouth. She is now referring to the day of the 5th, after the events of the night before. So because of the tachycardia, the tachypnea, and the vomiting, they've put the baby nil by mouth, straight back to square one. And he's now on a different level of baby Vin. And she's asked to document 150 mils per kilogram a day of 15% dextrose. So this was the 7 p.m. change to 15% dextrose. Junk everything else, go to 15% dextrose. And that was supposed to go over 24 hours, and it's supposed to have 5 mils per kilogram a day of something else in it, but we don't know what that is. And it also says to stop the TPN. So it seems to me logical that the TPN they're referring to is not a dextrose TPN. The dextrose was going in separately, and this needs to be checked out because ActRapid will not go evenly into solution into a bag of TPN that does not have dextrose in it. It's critical that whoever's analysing these cases needs to look at this constantly changing regime, and they're also to check for urinary sodium, cortisol, and insulin. So they're checking the urine for insulin. Now, it's usually, if you're going to check the urine for anything, you would check it for C-peptide. You wouldn't check it for insulin. But we don't have any result of the insulin in the urine. And then she goes on to say that 15% dextrose is a high amount. It's not a high amount. It's the amount that's needed. And an intensive care chart is showing that blood sugar levels, which are all low, even though they're all low, she said, but they didn't do anything about them. The 5 a.m. reading is 2.9, and that isn't bad, she says, for a neonate. And then readings of 1.9, 1.8 during the day up to 6 o'clock. And 10% dextrose solution administered at 3 and 4, so they have to be boluses. So instead of increasing the glucose infusion rate, they go for boluses, which is not advised by many places. Because again, you're going to lead to a surge in endogenous insulin production if you suddenly supercharge the blood with a 10% dextrose infusion. And then the intravenous blood test is sent to the laboratory at 5:56, is taken to go to the laboratory with relevant clinical details. And the relevant clinical details are preterm neonate, hypoglycemia, on 10% dextrose. That's what it said on the referral form. It doesn't say dehydrated, elevated urea, raised creatinine, low sodium. It doesn't say any of that. It doesn't give any information but that. That is not sufficient for a forensic test. And this test, which is a clinical request for a test to a laboratory that advises you not to send that particular sample immunoassay test to it, but instead to refer to the reference laboratory in Guildford, is now going to turn that clinical test into a forensic test in a murder trial. And the defense should have stopped happening, because forensic tests and clinical tests are two different things entirely. If you're going to do a forensic test, you have to have maximum control, and you have to forward all of the information that you have in relation to the baby or the patient that you're taking at the time. And then she goes on to talk about the difference between lab samples and bedside samples, which we know the bedside samples are no use when the blood sugar is low. And again, they shouldn't have been allowed into evidence because they're not proper readings. And she says that the insulin C-peptide was 4,657. But in spite of that massive amount of insulin in the baby, we still have a C-peptide reading of 169 or less than 169, which seems like a really weird cutoff point for me. And she tells us that the urine sample came back at 643 and there were no unusual readings. So there's nothing wrong, nothing in the urine, but we've 4,657 picomoles per litre of insulin in the blood, apparently. So Myers gets into the business of trying to find out what's going on here, but he doesn't know enough to keep hammering home, because he cross-examines Dr. Beach and he talks about the TPN, and he says on August the 4th, the fluids were being administered via TPN, the milk coming in via nasogastric tube with no lipids, because the baby was getting milk in, wasn't getting much milk in, or it was getting too much milk in. And then he says he refers to 2 August the 4th prescriptions for fluids, the first being crossed out. And Dr. Bates had completed the figures, and Dr. Bates confirms that's the case, that she signed for them. And at the first one, there's no component of lipid. And Dr. Bates said that would have been written after the ward round so that the TPN could be made up. And Dr. Bates says it would take some time from prescribing the TPN back to it being administered. And Myers asked for clarity on the second prescription with a different rate of administration of baby Vin and a new lipid and new 10% dextrose doses. So it's as clear as mud what he's saying. But again, it seems to me that they are feeding the total parenteral nutrition in 3 different components: lipids, electrolytes, and trace elements, vitamins, that kind of thing, and the dextrose, all 3 separate infusions going into the one line so that they can manage all 3 separately. That's what it looks like to me. The records will tell you whether that's true or not. And that is very problematic for this immunoassay test, if indeed this is the case. And the total administration is now 165 mils, and that rate is increased from 150 mils. So that's the total in a day that the baby is getting. And that concludes the evidence for BBF from Dr. Beach. So to me, it's as clear as mud what was actually going on with this baby here. So let's go back to this incident of the tachycardia and tachypnea. The tachypnea is going to follow the tachycardia, but the first thing that happened was vomiting. The baby had a large vomit, and that was followed by the fast heart rate. And to do an ECG, but I don't think he carried out that plan because it's not in evidence anyway. And they considered that the baby could have a thing called supraventricular tachycardia, but normally supraventricular tachycardia would be over 300. It wouldn't be 200. It wouldn't be dropping down to 160 to 170. So it seems likely to me that this was sinus tachycardia. And sinus tachycardia means a normal fast heart rate. After the baby has its distressing vomit, and it has a lot of acid from this milk that's been lying in the stomach coming up into the esophagus, which is just behind the heart, can we look for causes of the tachycardia? I think we can. First of all, we have to accept that the vomiting happened first. And there's a massive association between vomiting and supraventricular tachycardia. So supraventricular tachycardia is one of these arrhythmias that arises in preterm neonates quite commonly. And the range of beats per minute is anything between 200 and 300 beats per minute. So these people say that it has to be above 300 beats per minute. It doesn't have to be above 300 beats per minute. And the reason that the vomiting causes this problem, about 50% of these preterm neonates that have what's called gastroesophageal reflux, there's a significant association between supraventricular tachycardia and gastroesophageal reflux in neonates. So about 50% of newborns with SVT also have clinically significant gastroesophageal reflux disease. And it's the presence of the acid in the esophagus due to the reflux of vomit that can potentially trigger tachycardia due to the anatomical proximity of the esophagus to the heart. And this involves our old friend, the vagus nerve, so part of the autonomic nervous system. So vomiting involves an activation of the vagus nerve, but the vagus nerve in the preterm neonate is not mature. So paradoxically, this vagal stimulation can lead to a fast heart rate. Remember, the vagus nerve should be part of the parasympathetic chain, but because it's not fully developed, it can cause an elevated heart rate rather than a fall in heart rate. And then you get this weird thing that people have noticed and described, and it's a thing called the Valsalva maneuver. So the Valsalva maneuver is basically a technique used in adults to control fast heart rates. So it's you take a deep breath, you hold your breath, and then you strain as if you're going to pass a motion. And all of this combined has the effect of slowing down your heart. That wouldn't really work in a preterm neonate because you couldn't get it to do it. But there is evidence that in the early stages of the tachycardia, babies are able to unconsciously attempt to terminate the fast heart rate by strengthening the vagal stimulation through these mini Valsalva-like abdominal contractions. I'll give you the reference to that as well. But stress response, just vomiting is a stressful event for the babies, and that can activate the sympathetic nervous system and increase heart rate. And then, of course, we know in this baby that we have fluid and electrolyte imbalances. We don't know what they are. We know that at one point the sodium is low. We don't have the information, but electrolyte imbalances can definitely cause cardiac arrhythmias. That would be slow or fast. And then our old friend, inflammation. Vomiting is associated with inflammation, like every type of injury is, and mechanical irritation of the tissues near the heart. And that can potentially trigger arrhythmias as well. And if the blood pressure in these babies, which again is difficult to measure, accurately measure, if it's low because of the dehydration, you will get a compensatory tachycardia to try and keep the circulation adequate. So because we don't know whether the arrhythmia was actually SVT or it was sinus tachycardia, we can't know these things, but these are all well-known possibilities, and it isn't unusual for a baby who's vomiting to have a period of tachycardia following it. And in adults, that can be brought under control by the autonomic nervous system unless there's a pathological reason in the heart for the arrhythmia to happen. But if it's happening simply because of irritation or metabolic demands or things like that, in adults, the parasympathetic nervous system will slow it down. But that doesn't work in preterm neonates. So I think we have to follow the logic that the vomiting happened first, the tachycardia happened next, and of course, to keep up with the additional workload, the breathing rate had to go up. That's the most likely explanation. Now, we're going to get Professor Hindmarsh to come along later on and saying that hypoglycemia can cause vomiting. Well, if you have a list of symptoms that a preterm baby can have, vomiting is on every list. But in terms of hypoglycemia, vomiting would be way, way, way down at the bottom of that list. Your first thought wouldn't be, when you see a baby vomiting, oh, it must be hypoglycemia. That's just misleading. So we have an explanation, or likely explanation, for the event. And also we have to remember that the baby's line had tissued, using that awful word, but it had tissued. But we don't know when. So this baby could have been in pain from this hypertonic 10% dextrose leaking into it for hours before it became noticeable. So we have two reasons then: the tachycardia and the loss of glucose infusion and the lowering of glucose infusion rate because of the tissuing of the line. Both of those could explain the tachycardia and the falling glucose together. And that's the type of thing that you would be thinking about. You wouldn't be thinking, oh, somebody must have poisoned this baby with insulin. You wouldn't be thinking that way unless you wanted to think that way. In Hilary Mantel's wonderful biography of Thomas Cromwell, the last book in the trilogy is called The Mirror and the Light. And the mirror is a reflection of what you want to see without having to think about the mechanics of how the light makes the illusion from the mirror appear. And I think that's what we're dealing with here. These people are wanting to see an image in the mirror without having to work out how the light creates the image. These little babies are like flying an airplane that's being built while you fly it. That's the easiest way to put it. So you can imagine looking out the window of your Airbus A300 or whichever plane you're flying, and you see two guys out on the wing completing it. And then the pilot tells you halfway through that they have to turn the fuel pump off to fix it. And we're going to expect that plane to fly as if nothing was wrong. Nothing was wrong. Of course it's not going to fly as if nothing was wrong. It's going to crash, or it's going to do aerobatics or do whatever it's going to do. But that is basically what's happening with these preterm babies. But they're not depicted that way by these people. So I find it very easy to go, yeah, the baby has stress, it's got infection, it's just getting over this respiratory distress syndrome, traumatic birth, very low birth weight, hypoglycemic, dehydrated, and it's stressed to hell in this ICU. So it's easily going to get vomiting because they've overfed it. They're trying to feed it too quick, because they did say it was a large milky vomit and that the baby was put nil by mouth the following day. And that was the reason for the tachycardia and the vomiting, this event. And then, of course, they haven't bothered to take into account the extra workload that is now on the baby with this tachycardia and tachypnea, which is going to require more glucose. And the baby is on the edge of being able to keep its glucose normal. Well, if you throw extra work in on top of that, there's a good chance that that glucose is going to fall. And they don't seem to be making strategic attempts to get the glucose back up. It's reactionary attempts, boluses, rather than simplifying the glucose infusion rate, not worrying about all of the other things, just get the glucose right for this period of time, which is what eventually they do when they switch it to the 15% single TPN administration. And not only do they do it, but they overdo it because they don't check enough. So the baby goes from being hypoglycemic, it rockets up to 9 millimoles per litre, which is hyperglycemic, as they keep the 15% dextrose running. They can't manage these problems. That's how I see it. Very simple. But the case of BBL is even more ridiculous, because BBL, again, twins, low birth weight, premature, and they have hypoglycemia at birth. And what do we get? We have the baby admitted on the 8th of April, the baby on the 8th of April with a blood sugar reading of 1.9, and they put the baby on 10% dextrose, but we don't know at what infusion rate. And then they wait until 5:42 p.m. Then they check the blood in another hour, and it's gone up to 2.5. So they're on the right track. Then they check it at 4 p.m. and it's gone up to 5.8. So what's the problem? Letby records for BBL initially had some recession, but the respiratory rate was raised, but it's normal now, that's okay. So, but the baby's still stressed, and it's on 2 hourly feeds. This is just 2 hourly feed things again. And so they're going to be very, very small feeds. And at 6 o'clock, the blood sugar is 3.3. Then at 9 o'clock, 2.3. At 10 o'clock, 2.2. Then 3.6 at midnight. So what is the effects of this massive insulin doses? When does it come into the picture? The baby has hypoglycemia and is on a dextrose infusion, and the dextrose infusion is not enough. They need to turn it up, and that's it. So at 10 a.m. in the morning, with 10 p.m. being the last blood sugar measured, 10 a.m. in the morning, it's 1.9. But wouldn't you know that in the middle of the night, the cannula was knocked out, so it had to be reinserted. So I don't know how long that took when the baby didn't get its 10% dextrose. But if it's not getting its 10% dextrose, its blood sugar is not going to go up, and it's going to use up any stores that it has, which are going to be very low anyway. So after 10 a.m. and they get the 1.9, they decide to increase the infusion. But they increase the infusion at 11 a.m. 1.6. But we don't know if that's a lab test or a bedside test. Bedside test, useless. They wait another hour, 1.6 again. So where's the effects of this massive dose of insulin in this baby? Why don't they turn the infusion rate up a little bit more? Then they wait 2 hours and they do it again. And it's 2. And at 3, it's 1.5. So they've got more than enough evidence now that the glucose infusion rate is not enough. So just turn it up. And then, but they decide at 3:35 that they're going to take a blood sample for insulin and C-peptide to go to the Royal Liverpool Teaching Hospital. And instead of turning up the infusion, we're back to giving boluses again. So at 3:35, they give the baby a bolus of dextrose. So they know the baby needs more dextrose. So why give it a bolus of glucose? Why not just turn up the glucose infusion rate? But then we have a bit of a problem as well with this blood test that's going to go to the hospital that advises you not to send the blood test to it. They don't even pod. That means they don't prepare the blood test immediately because there's an emergency. So it's left. I don't know for how long. I don't know where. So there's no chain of custody, what we would call, for a forensic test that this is now going to be used for. Initially, it's going to be used for a clinical test. Now it's going to be used for a forensic test. But it's been left sitting on a bench somewhere because there's an emergency and no one can deal with it in the proper way that it's supposed to be dealt with. And at 4 o'clock, the bolus hasn't done much good because the blood sugar reading is still 1.5. 5 o'clock, 1.7, still haven't turned up the infusion rate. 6 o'clock, 1.9, still haven't turned up the infusion rate. 8 o'clock, 2, 9 o'clock, 2.4, 10 o'clock, 2.8, still haven't turned the infusion rate up. Midnight, 2.1, 2 a.m., 2.1, and they decide to insert a long line now. And the blood sugar reading at 4 a.m. is 2.3, 2.2 at 6 a.m., and it remains stubbornly low at 2.2. Turn the infusion rate up. So at 2 p.m. then, the following day, on Sunday, the blood sugar reading goes up to 3. And why do you think that is? Because baby L is now receiving 15% dextrose through the afternoon of Sunday. 5 p.m., 2.8, 2.7 at 9, 2.9 at 11, 2.7 at 2 a.m. So you would have had no chance of getting this blood sugar up without going to the 15% dextrose, which is no big deal. You use what you have to use. As I said in previous podcasts, you can go up to 20 milligrams per kilogram per minute if you need to. You rarely do, but you can go as high as you need to. It can sometimes take up to a week to get these babies into a euglycemic state. A week. And this has been a few days. And the baby's blood sugar goes eventually to 4.7. And we never hear another word about it again. But the baby was never made ill by, again, the catastrophic amount of insulin measured. So the insulin level comes back with 1,099 picomoles per litre, and C-peptide is 264. So the baby's still making a lot of insulin itself, even though Letby is supposed to have poisoned it. That can happen. Preterm babies are so dysregulated with this stuff that you can give them exogenous insulin and they'll still make their own insulin. But they're saying that the C-peptide should be 5 to 10 times the level of insulin. That applies to adults. It does not apply to preterm neonates. And in a study, the preterm neonates had a ratio of 0.44, which is completely different than you would get in adults. So this is a manufactured case. There's nothing in this that is at all unusual for a preterm baby. Nothing. The only reason that Letby is in this dilemma is because her name was Lucy Letby, and she happened to be on the ward at the same time as baby L. Nobody's seen her do anything. Nobody measured insulin in the bags. We've got this one insulin C-peptide test, which is inadequate for forensic use. Now we'll finish up this episode by reading a journal extract. So this is a case report. Again, it's just one case report, but these people have no problem using one case report, so why should we? And it's from the Journal of Pediatrics in 2010. And the title is The Detection of Surreptitious Administration of Analog Insulin to an 8-week-old Infant. So an 8-week-old infant presented to the emergency department with lethargy, tachycardia, and a blood glucose concentration of 1.8 millimoles per litre. Notice, it didn't present with vomiting. After admission, hypoglycemia occurred on 3 additional occasions. Initial urinalysis results were negative for ketones, and the results of additional laboratory tests did not support the diagnosis of cortisol or growth hormone deficiency, oral hypoglycemic ingestion, or an inborn error of metabolism. So you can see that unless you do all of those things, you don't know what you're dealing with. Difficulty restoring and maintaining glucose concentrations, along with a transient response to glucagon administration during one hypoglycemic episode, suggested hyperinsulinism. It didn't prove it. It suggested in one hypoglycemic episode, elevated insulin and low C-peptide concentrations suggested exogenous insulin administration. But 2 subsequent blood samples obtained during hypoglycemia contained appropriately decreased concentrations of insulin. The insulin immunoassay initially used in the case, Roche Alexis Cobra, that's the one they're using here, was insensitive to insulin analogs, so these are non-human insulin ones. So they did 2 additional immunoassays, one called Immulite and another one called Millipore. And reactivity to insulin analogs were used to characterize insulin in each of the critical blood samples. And the samples obtained during hypoglycemia displayed a graded reactivity similar to that observed in a type 1 diabetic who was taking the insulin analogs. Whereas a sample obtained from a patient and a control subject during euglycemia, normal blood glucose showed equal reactivity amongst the 3 assays. So they did 3 assays in different patients to reach their determination, but they didn't stop there. This data suggested administration of an insulin analog to the child and further characterization of insulin by using tandem mass spectrometry confirmed the presence of Humalog, the analog insulin. The child was subsequently placed in foster care and no further recurrence of hypoglycemia occurred. So this is what's called forensic medicine. This is the forensic analysis that you need to do in order to reach a definite conclusion. You don't just do one random test and use that one random test that was taken for a different purpose. The Alexis Roche test says clearly on the sheet insert that it's for the in vitro quantitative determination of human insulin in human serum and plasma. It is intended to aid in the diagnosis and therapy of various disorders of carbohydrate metabolism, including diabetes mellitus and hypoglycemia. It is not intended, in other words, to prove the presence of exogenous act rapid. Even though it reacts well to act rapid, it's just not good enough. This is not proper forensic medicine. This is a mirror and the light. The mirror is showing you what you want to see, but you're not interested in how the light creates that illusion. Unless you do the mass spectrometry, you cannot know, full stop. So in episode 40, we will look at what Professor Hindmarsh had to say, and Anna Milan and Miss Walk had to say, and then we'll finish these. But I have no idea how these charges became indictments. I have no idea why these immunoassays were allowed into evidence, and that there was no request from the judge to not allow them into evidence. I have no idea why an expert in immunoassays didn't give evidence on behalf of Letby. And I think that the use of these things is a route in, I hope, to a retrial or whatever will have to happen in the case of Lucy Letby. But this doctor thinks this is fake medicine, that you wouldn't practice medicine like this. Every time you got an aberrant test that was so outrageously high, you would repeat it. And if the clinical presentation of the patient did not fit with the test, you would not go with the test, you would go with the clinical presentation. They successfully treated these babies by increasing the glucose infusion rate. That is just a clear case of carbohydrate homeostasis dysregulation in everyday life of preterm neonates. There's nothing more to it as far as I'm concerned. So we'll see you in the next episode. Bye.